Hello, everyone. Thank you so much for joining us today. My name is Jacqueline McGrade, and I'm the sales director over at Belmont Village Coral Gables, our newest community under construction. I would like to introduce our speaker, Dr. Jane Mendez, Chief of Breast Surgery for Baptist Health. Dr. Mendez is a surgical oncologist at Miami Cancer Institute, a part of Baptist Health South Florida. Dr. Mendez specializes in the treatment of breast cancer and performs all types of breast surgical procedures. She received her undergraduate degree from Harvard University and her medical degree from Mount Sinai School of Medicine in New York. She also completed a surgery residency at Mount Sinai Hospital. Renowned for her patient care and advocacy, Dr. Mendez is passionate about educating patients and advancing breast cancer awareness and prevention outside the hospital setting, in the community, and at national meetings. She has also served on the governing board of Susan G. Komen, Massachusetts affiliate. She is a fellow of the American College of Surgeons and an active member of numerous professional societies, including the American Society of Breast Surgeons and the Society of Surgical Oncology. Please welcome Dr. Mendez, Chief of Breast Surgery for Baptist Health South Florida.
Thank you very much, Jacqueline, for such a wonderful introduction. And thank you for the invitation to be part of this webinar this afternoon. I'm very excited to be here. As you mentioned, it is one of my passions to educate the community pertaining to breast cancer. And this afternoon, I'm happy that you have all joined us to talk about breast cancer basics, prevention, screening, and treatment. And also I started looking a little bit about the Belmont communities, and I uncovered in your website about the unique partnership with Baptist Health. So I'm very honored to be part of this process and to be part of this community. I have no financial disclosures as part of this presentation. So this is what Miami Cancer Institute looks like, especially lit up in the month of October, which, as you know, is the Breast Cancer Awareness Month. It's a 400,000 square feet where we provide all the services under this roof pertaining to all sorts of different cancers. And I'm in charge specifically of the breast surgery service, which accounts for about 28% of all the cancers treated at the Miami Cancer Institute. So the objective this afternoon, I would like to discuss the breast cancer burden around the world. Then we're going to review some of the breast cancer risk factors. Then we're going to talk about and discuss breast cancer risk reduction strategies. And at the end, I would like to debunk some important breast cancer myths. We know that every 2 minutes, a woman is diagnosed with breast cancer in the United States of America. When you think of it, I don't think there's anybody in this webinar connected right now who doesn't know someone who's been impacted by breast cancer. We know that 1 of 8 women will develop invasive breast cancer during their lifetime. We also know that there's 42% higher breast cancer mortality rates in African American women as compared to those in white women. And we also know that the breast cancer, the most common cancer in Hispanic or Latino women, and the leading cause of cancer death in this group. Put another way, 99% of breast cancer patients are women. It is the #1 type of breast cancer in women worldwide. In the United States, it's the second cause of cancer death, first one being lung, as smoking habits have significantly increased over the past few decades. And nowadays, secondary to all the incredible multidisciplinary approach, advances, and research that we have pertaining to breast cancer, we have over 3 million survivors in the United States alone. So a testament to all the work that has gone to treat this disease. And I have to say that today, as of 2023, if we diagnose breast cancer early, we expect at least a 98.5% survival at 10 years. So all a testament to all the hard work that has happened over the past few decades. I really want to stress this point, and that is that the breast cancer incidence increases as we age. So even though we like to forget about breast cancer, the older we get, these numbers speak by themselves. As you can see here, if you're in your 50s, 1 of every 50 women will diagnosed with breast cancer. By age 60, that's 1 out of 24. By age 70, 1 of every 14. And by age 80, 1 of every 10 women will be diagnosed with breast cancer. So needless to say, the older we get, they are the likely to possibly develop breast cancer. So we cannot forget about breast cancer, even if we wanted to. Around the world, breast cancer accounts from anywhere between 19 to 28% of all cancers around the world, irrespective of what continent you are. So this is a very important topic for public health, irrespective of where we are in the world. And furthermore, the outcomes about breast cancer are definitely related to where you are. If you're in a high-income country, we expect about an 80% survival for all stages, whereas if you are in a low-income country, it's more like 40%. And that's definitely associated with multiple factors such as access to care, technology, research, and educational level of the patient. So it's drastic difference how you will do pertaining to your breast cancer where you are treated in the world. And we know, and nobody will argue with me, that when a woman, feels a lump or feels an abnormality in her breast, it's an anxiety-provoking, moment. There's a sense of urgency, and for the most part, everybody I met in this situation, they want the things treated yesterday. But as physicians, we have a fundamental task, because we know that not all breast lumps are necessarily breast cancer. So my fundamental task as a physician is to make sure if this is something benign or something malignant. So our best and most important tool to start to address this problem is mammography, which is the gold standard for breast cancer screening. And currently, as you can see, we usually do for the screening mammogram 2 views of each breast, what is called the MLO, which is from the medial to the lateral aspect from side to side, and then the cranial caudal view or CC view, which is up and down. So that's why they squeeze you, and the technicians are so carefully positioning your breast within the plates of the mammogram machine so we can get these views. Sometimes we need to complement the mammogram with an ultrasound. And especially for women who have very dense breasts, this is a very helpful tool, with the added benefit that if we see something on the mammogram, we may do biopsy through ultrasound or through mammogram as well. So the two are complementary. And nowadays we know that obviously sometimes we need to do what are called diagnostic mammograms, which is that in addition to the 2 views that are already mentioned, the radiologist might order additional views, either for magnification or to see more detail, any abnormality that they had seen on that screening mammogram. So you might be called back to have additional films just as part of that workup. And now, at least at Baptist Health and our facilities, we have 3D mammography, which is a 3D reconstruction of the whole breast, which is a computerized aided system that allows us to see even earlier potential abnormalities on the mammogram. So this has proven to be a very helpful tool for even earlier detection of things by mammography. And at least I know Baptist Health facilities, the 3D mammography is the standard, and we have been able to catch cancers in even earlier stages. I want to mention a couple of things about breast MRI. Breast MRI is the most sensitive tool we have to evaluate the breast. However, it's not a screening tool. So for selected patients, depending on the given abnormalities, that it be clinically or by a mammogram or ultrasound, it might be necessary to obtain a breast MRI to get more information. However, this is only for selected group of patients and usually very well tolerated, but definitely not part of the screening tools that we have for breast cancer, only as needed. And I'm sure you're dying to ask me the $1 million question, which is probably, when should I stop having my mammograms done? Before I answer that question, I will tell you what the American Cancer Society and we recommend about this health now pertaining to mammography. You should have a mammography done annually starting at age 40 and annually thereafter. And currently there's no stopping date to when a mammogram should be done, provided you're in good state and you're willing to have treatment if something is identified on your mammogram. So to answer that $1 million question, currently there's no stopping dates to getting your mammogram done, providing you're healthy and provided you have a good performance status and provided you are willing to receive treatment if something is found, you should be getting your mammogram still. Certainly discuss it with your primary care doctor, your gynecologist. But 2 months ago, I operated a 99-year-old patient, who had presented, she had been very delinquent, and that was her first mammogram. But she had an abnormality and ended up requiring surgery, and she went even home the same day. So again, this is a conversation you need to be having your primary care doctor or your gynecologist. But if you're healthy and you're willing to receive treatment, there's no stopping days to when you should have your last mammogram. So there's certain issues that we have to discuss pertaining to mammogram. A lot of women, because of the pandemic, decided to delay having their mammograms performed. So if you are in that group of patients who delayed having the mammogram because of the pandemic, I encourage you to go ahead and have it done and make an appointment, because what we've seen is with the delayed imaging, we're seeing later diagnosis. So really important to have your mammograms done if you haven't already done so. And ladies and gentlemen, for the time being, the mammogram remains the gold standard. So I know it might not be that convenient, or it might be somewhat painful to have it done. Is necessary because with early detection, certainly, as they say, we may save lives. So if you haven't done so, please schedule your mammography. Now I'd like to change gears a little bit and talk about some of the basics beyond screening. So I like to reiterate that the two main single risk factors for breast cancer are being a woman and getting older. So these two factors we cannot change. So only about 10% of breast cancers are familial, meaning that you have it somewhere in your family, and 5% hereditary, meaning that we can identify a genetic mutation associated with the breast cancer. But the important number here is the 85%, which are sporadic, which means that it happens out of the blue. So I would like to emphasize that even if you don't have the family history, and even if there is no genetic mutations in your family, the vast majority of patients with breast cancer don't have that. So if you're getting older and you're a woman, that's your highest two risk factors. In addition to that, obviously, we can break the different breast cancer risk factors into modifiable and non-modifiable. I'll first address the non-modifiable. We already talked about age. Breast cancer, we know that it increases the future likelihood of developing a second cancer. When you have certain pathologic conditions that we know are higher risk, such as lobular carcinoma in situ or lobular neoplasia, and ductal carcinoma in situ, or those ones intraductal cancer, certain family history, certainly if there are mutations that are in your family, such as the BRCA mutations, and Angelina Jolie made those very popular. That was already 2014. Hard to believe that it's almost 10 years since she went public with her own story. Radiation exposure. When you have your period at a very early age, which is early menarche, when you have your period till very late, so a late menopause. And the reasoning behind that is you have a longer exposure to estrogen. Nulliparity or not having any children. When you had your first live birth after age 30, when you've had previous breast biopsies, And then certainly this last factor is something that is probably incidental, because the women who usually have higher socioeconomic level as well as insurance are the ones getting screened. So this might not necessarily be a factor by itself, but certainly we know this is the women who are usually getting screened more frequently. And I'd like to mention, besides the BRCA1 and BRCA2, there's other mutations that we need to be aware of as associated with breast cancer. So the P53, which is also associated with colon cancer, P10 or Cowden, which is also associated with breast and colon, and ATM, as well as HTK11 Peutz-Jeghers syndrome. So it's not the BRCA1 or BRCA2. There's at least 8 breast cancer related mutations that if a patient is identified to have any of these 8, it will be actionable and have implications in terms of the treatment or the prevention strategies. And there's some red flags when it comes to the BRCA1 and BRCA2, which are the most prevalent genes associated with breast cancer. When you have breast cancer before age 50, ovarian cancer at any age, if there is male breast cancer in your family, multiple primary cancers, and of Ashkenazi Jewish ancestry. We know that there's certain ethnic groups that have higher preponderance of having these genetic mutations. So at least in my practice, I'm always asking the patients very targeted questions about their family history. So I try to stratify their breast cancer risk. And as identified, then I will go ahead and, if necessary, refer them for genetic counseling, because with more information, we can make better decisions, not only about treatment, but also about prevention, not only for breast cancer, but other cancers that might be associated with that particular gene if one is identified. So now is the probably hardest part of the conversation, those factors that we can modify. So the modifiable risk factors include diet, sedentary lifestyle, alcohol consumption, environmental exposures, and estrogen replacement therapy. So I'll say a couple of words about each of these. When it comes to diet, there's no perfect diet. We've been inundated with all sorts of different diets available, from the South Beach diet to the Atkins diet to the Mediterranean, you name it. But bottom line is there's no perfect diets, and sometimes it can be overwhelming. And the food pyramid, as you know, has been altered over time, but some things have been consistent all along. Definitely we should be having at least 8 servings minimum of water daily, at least 2 to 3 servings of milk, yogurt, or cheese, 3 to 5 servings of vegetables, and then 2 to 4 of different fruit groups. And we need to minimize the use of fats, and usually we need to do those that are unsaturated fats. And as you know, there's some healthy fats that we can eat, such as nuts, avocado, and others. Our proteins, meat, poultry, fish, beans, and other legumes that are great protein sources. And we are to reduce most of the time all the things that we like the most, like bread, cereal, rice, and pasta. We should limit those, not only in terms of the portions, but the servings, and the alcohol in limited quantities. So what does your plate look like? So we have to be very mindful of not only what we eat, but also the portions on our plate. And I guess this looks like a beautifully crafted plate. I don't know how many of your plates look like that, but certainly we need to aspire to include a lot of the vegetables and fruit, our lean meat, and all about the portions. And another point that I would like to make, you could have the healthiest food, organic product available, but if you fry it or you put it in significant amount of oil, we defeated the purpose of that very good organic product. So we have to be mindful not only of what we eat, but how we prepare the foods. And again, here, just a reminder of drinking a lot of water, which is really important every day. So when it comes to that, I think the most important is make healthy choices, know your body. We all have different metabolisms. And certainly it's always nice to speak to your primary care doctor or a nutritionist about how many calories you should be ingesting per day, given your activity level, given your age, given your own body metabolism. So it's important to have those conversations because most people tend to overeat. Next, I'm going to move to exercise. So you can see here in this cartoon, my whole routine lasts an hour and a half. 15 minutes of cardio, 15 minutes of weights, and an hour of talking myself into it. Who cannot relate to that? Certainly, it's really important to keep our bodies moving. It's not necessarily about only going to the gym. It's about getting our heart rate up and obviously staying constant and moving much of the day. Certainly, there's many different options, from yoga, and there's many different types of yoga and meditation to strengthening exercises. Water, there's very low impact exercise that you can do in the water aerobics and swimming, which can be a great exercise for our joints, Tai Chi and others. And I've learned a lot about this from my patients because it's critical to stay fit, and it translates not only to breast cancer prevention, but also control of your diabetes, high blood pressure, and your heart health, which go hand in hand with everything else. So I encourage you to see what you like. Sometimes it's finding what the right exercise activity for you. It might be just walking with your dog or walking with a neighbor around the neighborhood. But the key element is to be active and try to get your heart rate up. Alcohol. What about alcohol? So turns out that alcohol in moderation, as I mentioned already, but there's no direct link associated with alcohol and breast cancer by itself. However, there's indeed risk of alcohol associated with liver cancer. So we have to drink in moderation. And I should say that if you are going to drink, red wines contains phenolic acids, and it's supposed to be protective against breast cancer. So if you're going to drink and you have a choice, I would encourage you to, at least in moderation, try the red wine because of the phenolic acids that could help reduce your breast cancer risk. The next one is smoking. And smoking, actually, there's not a direct link between smoking and breast cancer, however, there is with lung cancer. And lung cancer right now in the United States is the #1 cause of cancer death in women. So obviously a lot of women have acquired smoking habits, and this has become an issue of public health concern, but there's no direct link between smoking and breast cancer. Next is a very hot topic, hormonal replacement therapy. And I cannot tell you how many times this is a very controversial topic, but now we have enough data to really support that there's indeed a link between hormonal replacement therapy and breast cancer, especially when there's chronic hormonal replacement therapy over years and years. Probably at this point weekly, I get at least 2-3 patients who have been on hormonal replacement therapy for 10, 15 years because obviously they like the way it makes them feel. You feel that you have your youth, you think that it's protecting your bones, it's good for your heart. But the longer you are on the hormonal replacement therapy, the higher the potential to further increase in your risk of breast cancer. That, as already mentioned, just by age alone is a risk factor alone. So what I would encourage to do, if you have been on chronic hormonal replacement therapy, speak to your physician about, perhaps substitutes for that or not, or what alternatives you have. And I know that the patches, there's the pellets, there's also the bioequivalents. Hormones are hormones. So certainly it's an important conversation that any of you who are on hormonal replacement therapy should have your doctors, so then you can get the appropriate treatment for whatever postmenopausal symptomatology you are experiencing. because there's some non-hormonal treatments that could be rather effective to treat some of the hormonally associated menopausal symptomatology. So just a word of caution, because I see well too often not to mention this issue, the hormonal replacement therapy. So if I were to summarize, some of these lifestyle modifications that are recommended for all women, number one, weight control. Certainly no cigarette smoking would be desirable. Decrease alcohol consumption, everything in moderation. Exercise and to what's appropriate for your body, your activity level, and any other medical problems that you might have, with the proper guidance from your physician or physical therapist. And then avoid non-diagnostic ionizing radiation. So I think if we do that, even though it's not foolproof, at least we're doing what we can from my end to modify some of the risk factors that might be associated with breast cancer. And I could not stress enough the importance of clinical examination. At least everyone 40 and older should have a clinical breast exam performed by either their primary care physician, their gynecologist, whomever is the provider is doing it. And along those lines as well, very important for you to be familiar with your body, because that way you can detect any changes that might then have you seek medical attention. But if you don't know what's normal for you, how could potentially identify something that has changed? So now I'd like to change gears again and address some of these breast cancer myths that are out there. So I thought it would be a good opportunity to try to debunk some of this. Are you guys ready? I am. All right. Myth number one, I already tackled this one. Myth, only women with a family history of breast cancer are at risk. So I think we have already established that that's not the case, that 85% of women with breast cancer, it happens out of the blue, and only the minority, 10% are familial and 5% hereditary. And I cannot tell you how many times when the patients are first diagnosed, as the first thing that they mentioned to me, that they didn't have it in the family and they don't know why it happened. So I remind them of age alone and being a woman have been the two most single risk factors. So remember, even if you don't have any family history, we need to worry about screening. Myth number two, wearing an underwire bra increases your risk of breast cancer. Happy to say this is not true either. Underwire bras are notorious for perhaps causing breast pain. And anytime when I have a patient who comes to the clinic complaining of breast pain, this is one of the first pieces of advice I'm going to give, because the wire puts a lot of pressure in certain parts of our breast that might be attributed to the breast pain, but underwire bras by themselves do not increase the risk of breast cancer, but it might increase the risk of breast pain. Myth number three, breast implants can raise your cancer risk. This was controversial for a really long time, and for almost a decade, the silicone implants were banned. There was a moratorium to the silicone implants. However, after significant amount of research, they were not able to prove that there's any direct link between breast implants and increased risk of breast cancer. Over the past few years, there's been a type of lymphoma, which is called an aplastic large cell lymphoma, that has been associated with a very specific type of implant, which is called a texturized implant, which since then has been removed from the market. But nowadays, with the implants that we have, either silicone or normal saline, this is not thought to be an increased risk factor for breast cancer. For those who have implants, something just to keep in mind is that they have to modify the technique by which they do your mammogram, because they have to displace the implant so we can see the breast tissue for itself without the implants in the picture. Certainly that takes a really skillful technician to do it, but obviously they do it all the time, and that's how we can visualize the breast tissue by itself. But there's no increased cancer risk with breast implants at this time. Myth number 4, wearing antiperspirant increases your risk of breast cancer. Luckily, this is also not true. So along these lines, I've also heard about coloring, your hair dyes, antiperspirant, and others. However, this is not true. It has not been able to be proven by any of the research. So no link between antiperspirants and breast cancer. Myth number 5, breast cancer always comes in the form of a lump. Actually, that is not true. Other kinds, we need to be vigilant because breast cancer may present just a swelling in the area under the arm or in our breast that is we cannot explain by anything else. Some skin irritation or dimpling might be changes in the nipple, such as retraction, or that is turning inward, or that is slightly deviated, and we know that change. It could be redness, scaliness, or thickening of the nipple or the skin in the breast. And then a bloody nipple discharge is sometimes somewhat concerning. So breast cancer does not always present as a lump, and most breast lumps are not cancer, which is also true, because if it's a lump, it could be a benign mass like a cyst. It could also be a fibroadenoma, but we can never assume. So we always have to do the proper workup with mammogram ultrasound because we cannot assume what it is. And then if necessary, we can proceed with a needle biopsy. So very important to underscore that the breast familiarity and the breast exam is critical because 33% of the time is the woman who discovers the lump in her breast. So again, if you don't know what's normal for you, how can you seek medical attention? So I know that from some cultures, it might be taboo to examine the breast or to touch the breast, but it's something that is free of charge. You don't need an appointment. And that familiarity with your own breast could save your life. And I wanted to summarize in this diagram the different things that you should be looking for. So the texture change, some visible drainage from the area of the nipple, any lumps in the area under the arm or the armpit, any color changes in the breast, the changes in the nipple, such as inversion or retraction, bloody discharge, and dimpling of the skin. And one that we don't see as often, but also is important, if you see that one breast is getting a lot smaller or a lot bigger as compared to the other. So an acute change in the size of appearance of the breast for no good reason. If you have a trauma to the breast or a certain injury, then we have an explanation, but we can never assume if you detect these size changes that are unexplained otherwise. And before this next myth, I would like everybody to take a deep breath because this one might be life-changing. Okay, are you guys ready? Coffee. So the myth number 6, caffeine causes breast cancer. I have good news though. There's no causal relationship between drinking caffeine and getting breast cancer. And actually, last year they published a very large study of over 70,000 patients, and they found no correlation between caffeine intake and breast cancer. However, there's a very close link between caffeine and breast pain and fibrocystic changes. So when I have women who come complaining of breast pain, one of the first questions I need to ask, are they drinking a lot of coffee or any caffeinated product for that matter? Coffee, tea, sodas, chocolate, which is also caffeinated. And obviously, but at least there's no link to breast cancer for the women who come with breast pain. After they reduce the caffeine intake, they usually get improvement of their symptoms when it comes to the breast pain and the fibrocystic changes, but at least enjoy your cup of coffee, no link between caffeine and breast cancer. So now I think we need to take a pause And obviously, we've come really far in terms of the breast cancer treatment. We've learned about the risk factors. And we have to make a lot of choices, because a lot of these prevention strategies have to do with choices that we can make. So we need to take baby steps, and each person is different. So you'll have to take a look at what you need to do from your end in order to reduce your own risk. Certainly here, I want to talk about when you have it in your family, you obviously need to know that information. The more you know about your own family history, the better decisions we can make. And we're here, Baptist Health, Miami Cancer Institute, healthcare begins here, but actually it all starts with you and every one of you as you decide on what are the best options pertaining to exercise, to your diet, to your alcohol consumption, and to other entertaining chemicals that we might like. And there's no doubt that best defense is find the breast cancer early. So we have homework, and we're still trying to catch up actually from some challenges that we have already passed almost 3 years pertaining to the COVID-19 pandemic. A lot of women decided not to get their imaging performed because of the pandemic. And we still have a lot of patients who it's been 2-3 years since they had their last mammogram. And what we are seeing as a consequence is that we're seeing later stages of disease. That whereas if it's early stage, we might just be able to do surgery and then radiation and take a pill. Certainly when it's more advanced stages, we have to consider chemotherapy and other more aggressive treatments because there's more and more advanced disease. So we're still catching up, and this is not exclusive to breast cancer, but this has been seen also in colon cancer, lung cancer, because individuals haven't been following the screening guidelines. So when it pertains to breast cancer, don't let them out of your sight. Breast cancer prevention. Certainly, it's important to check yourself. As I already mentioned, it's free and you can do it. You don't even need an appointment. If you don't know, how can you seek attention? Know your lemons. This is another way to kind of summarize all the things that you could be looking for when you do your breast exam. Easily to be done, with the mirror, as you look at yourself as you're getting dressed or you're in the shower. So thickened areas, dimpling, nipple cross, when it's red or hot, any new fluid, any skin sores, any hard lumps, when the skin feels like an orange peel, when you see a new shape or different size, sunken nipple, which is also retracted nipple, if you see any prominent vein in the breast, or if you see any new bumps that were not there before. So know your lemons, sit down and feel around. Keep calm and carry on. Preventing breast cancer bite by bite, step by step, drop by drop, breath by breath. As we continue to take the breast cancer detour, hopefully. And I'd like to mention again, 98.5% survival at 10 years. If detected early. So this is something that is extremely curable with early detection. So embrace tomorrow by getting your mammogram today. If you haven't scheduled your mammogram, do so. Here's actually the information here at Baptist Health. We make it easy so you don't have to worry about it too much. And if you are not here in Miami, certainly each of your facilities probably has centers nearby that try to make it easy for you to have it done. And we're here to serve our community. And I'm privileged to work with 4 other breast surgeons, all of whom, obviously, we provide the best care to our patients as much as possible, all under one roof. And we have a very competent and distinguished group of breast imagers who also work with us, and we're a part of this very large family. So with that, we are in this together to stop breast cancer. And I'd like to thank you for your attention and happy to answer any questions. And again, if you haven't done so, go get your mammogram. Have a wonderful afternoon.
Thank you so much, Dr. Fernandez. We do have a couple of questions that came through the chat. The first one is, why does the risk increase as we get older? Is it environmental factors? Is it the food we eat?
Yes, it's actually cumulative factors. But we know that as we age, our body loses the check and balances systems that we have to control cancer cells. So that's why all types of cancer increase in number as we age, in men, prostate cancer, in women, breast cancer, and others. So it's just that our body loses the ability to keep our normal cell growth in check as we age.
Thank you so much. The next question we have is, if the American Cancer Society recommendation is to continue screening as long as a patient has good overall health and a life expectancy of 10 years or longer, how do you factor in the life expectancy factor?
That has to be calculated with the performance status, okay? Because I have 80-year-olds who come and they're younger than some in spirit and in activities, some of the 40-year-olds I see. So performance status becomes really important, and therefore the calculation for possibly 10 years of life expectancy. So, going back to the case of the 99-year-old that I treated, she only took an aspirin a day. She lived with her family. She did all her daily activities. And even though she had breast cancer, and I would have just tried to minimize the treatment, she really has a full life ahead of her. Her sister lived to be 104, and her mother till she was 105. So we have to take everything in the context of the individual and their performance status. After her, I had a 93-year-old who still works 5 hours per day, and she's an insurance agent. So not all the patients, it's not about the chronological age per se, it's about their performance status and that age. So I have some very spunky and active 90-year-olds, and we need to treat them if they get sick.
Okay, next question. Can you speak to how procedures like mammograms, ultrasounds, and breast biopsies may be more painful or frightening for older women who have cognitive impairment, and how surgery or chemotherapy may negatively impact quality of life without prolonging life?
Yeah, so, we have, again, it's all about individualizing the care, Jacqueline. And not all patients can be treated the same. There's no cookbook recipe. So not only do we need to take into account patients' individual issues about other medical problems or cognitive impairment, but we also have to take a look at what type of breast cancer they have, because we don't treat all breast cancers the same. There's many different subtypes of breast cancer, and also depends on the stage. But this question brings up a very important question, which is, where do we draw the line? The fact that we can cure something at what price? So I always say to the patients that my goal is to maximize their cure, but at the same time, I have to keep it balanced with their quality of life. Because a lot of the treatments that we can give to cure breast cancer have a lot of side effects, some more nauseous than others. So it's a very careful conversation and very detailed conversation that we need to have, not only with the patient, but sometimes with the family members, especially somebody with cognitive impairment. So we can find out for that given person, what does that look like? Taking into consideration not only the type of cancer, but other medical problems, as well as their performance status and the patient's own wishes. I cannot force cancer treatment to anyone. So these are very, very lengthy conversations that we need to have with patients individually, and in somebody who has cognitive impairment or physical handicaps, we need to go ahead and include their family as part of the conversation, because it's not easy. There's not a cookbook recipe. So it takes a lot of time and consideration of all the factors.
Thank you. The next question we have is, do bioidentical hormones for osteoporosis also increase the risk of breast cancer?
I have not heard of bioidenticals for osteoporosis to be part of the group that we're concerned about. and certainly osteoporosis is very common. But I have not heard of bioequivalence for osteoporosis being the culprits as being associated with breast cancer risk.
And then another question, if we have a higher chance of getting breast cancer as we get older, should we get a mammogram more often as we age?
Yes, so the answer to that is no. And they've done studies looking at what would be the excess radiation, and also it takes time to the changes to develop in the breast. So letting it, unless there's something that we're monitoring already by the mammogram or ultrasound, that the radiologist recommends 6 months follow-up, it's not necessary to do it more frequently than 1 year, because it takes time for the changes to develop so it can be picked up by the mammogram or the ultrasound. Because at that point, obviously, we have to take into account the additional radiation that the individual would be exposed to. So at the end of the day, it's not recommended to do it more than the year, even as we age. But yes, if they see something that they're monitoring mammographically, and that's at the discretion of the radiologist.
Okay, and does breast cancer hurt? In other words, if you find a lump and it is painful, does that indicate it's breast cancer or not?
Very important question. Usually, breast cancer does not hurt. So if somebody has breast cancer and it hurts, it's usually already a little bit more advanced stage. Okay, so when you have a lump and it hurts, yes, as I mentioned at the beginning of the presentation, it has to be worked up. We cannot assume what it is, but a painful lump in the breast might be a cyst, might be a fibroadenoma, might be fibrocystic changes, but breast cancer usually does not hurt. So that's why we have to be vigilant. So if we're waiting for something to hurt, it's going to be too late.
And why do European countries recommend a mammogram every 2 to 3 years in women 45 to 74 years old?
You're right. There's been a controversial area for many years because Europe and the States, we have very different views of breast cancer, but at the same time, places like the UK, not all breast cancer patients are treated. They have guidelines because they have the national health system. So at least here in the United States, everybody who has insurance, and even those without insurance can have access to care. So we have very different guidelines in terms of who can and cannot be treated as compared to European countries. And even here, the United States Task Force, last time they published here, even in the States, they recommended mammogram starting at age 50, but they didn't take into consideration what that represents in terms of delayed diagnosis when you wait till age 50. And most of the new breast cancer cases that we see nowadays are in the ages 40 to 50. So even more reason to follow the guidelines established by the American Cancer Society, American College of Radiology, the College of Gynecologists and Obstetricians, because we know that this is a very vulnerable group and we will be delaying diagnosis and hence outcomes. But we cannot compare European countries to our country when it comes to that.
And should women with dense breasts have additional screening for breast cancer?
Absolutely. So it turns out that it probably dates back to 2015, where many states mandate that if the patient has dense breast, they have to inform you that indeed you have dense breast and that you need to communicate with your primary care provider, whomever ordered your mammogram, to have additional imaging. And this stems from a fact that happened in Connecticut, where there was a woman whose cancer was missed because she had very dense breasts and years subsequently was diagnosed with breast cancer. And there's many states in the United States right now that mandate the patient being informed officially through a letter and to have the additional imaging done, let it be ultrasound or any other adjunct if they have very dense breasts. Why? Because we know the breast density lowers the sensitivity of the mammogram. So it's really going to be under evaluating the patient when there's very dense breast, which brings another question. When women have been taking hormonal replacement therapy, that makes the breast really dense. So now I have a woman who's higher risk, and I know the mammogram is not going to go well enough because of the breast density. So you have all these competing forces. But yes, this is, and actually Florida is mandated. So we already have it here that our patients need to get a special notification of their breast density and what else they need to do in order to be properly evaluated.
And can breasts change, for example, fatty and then dense, or once they are determined to be fatty or dense, do they remain that way?
So interestingly, as part of our physiology, the younger we are, the denser the breast tissue. Okay, and as we get older, the breast tissue itself gets replaced by fat. So that's why mammogram is recommended starting at age 40, because that's when we see those, that breast tissue to turn more into fat. Because the younger you are, it all appears just like white, so you cannot really differentiate. So yes, it's expected as we get older, and we might not like it, breast gets saggier, more pendulous, and fattier. But it makes it a lot easier to find things on the mammogram, okay? And obviously one of the challenges is the women who are on the hormones, because their breasts will remain dense irrespective of their age.
And can breast cancer cause swollen lymph nodes in the neck?
Swollen lymph nodes in the neck and breast cancer. Well, breast cancer usually does not skip levels. So the first place where cancer would spread to, when if it started in the breast, is here in the area under the arm, the axilla or the armpit. If the cancer has managed to get to the axilla or underarm, yes, it could potentially spread to the area above the clavicle here, because obviously that's in the same line of lymph nodes. But very seldom is that the way it's presented. Because if there's something under the arm, it should not be in the neck.
Is it ever safe to stop receiving mammograms after reaching a certain age?
I think, again, if you're willing to have treatment and if you have a good performance status, and as women continue to live longer lives, and we know that the incidence increases as we age, unless your doctor tells you not to, I think there's no reason to stop if you're willing to receive treatment.
Can hormone imbalance increase the risk for breast cancer?
That's a tough one to answer. Hormone imbalance, again, not knowing what type of hormone imbalance that would be, but certainly, even though with menopause, we don't have a period, our own body still produces, a minute amount of estrogen and progesterone, our female hormones. So let's say if we have some excess testosterone, that will lead to virilization and probably on facial hair growth and other things. So that by itself would actually decrease the risk of breast cancer. So hormonal imbalance, meaning excess estrogen, yes, because that's most breast cancers respond to the estrogen. So that's why the hormonal replacement therapy is so, has to be taken with caution, and is so challenging because we have excess hormones when the body is already menopausal. So we have to keep everything in check.
And one more question. What are some of the latest developments in the field of breast cancer that you see most promising?
Yeah, so I'm telling you, I've been doing this for 30 years, and it's so exciting because we've started to understand a lot more about the different types of breast cancer. And there's this push to do what's only necessary to maximize the cure, and do so in a way that's individualized to the patient and tailored to the patient and the cancer that they have. And one of the most impactful advances has been being able to, as needed, send the tumor tissue for analysis, what we call genomic profiling, so we can get a better idea whether the patient will benefit from chemotherapy or not, as we try to minimize the side effects of the treatment while we cure the cancer. And another exciting area is we know that one size does not fit all, not only because of the type of cancer, but also different age groups. Obviously I cannot treat and the issues of a young cancer patient are not the same as somebody who's elderly. So we're trying to, in certain groups, try to minimize. So for example, in women 70 and older, for selected patients who have very good tumor characteristics, we might omit the radiation. They might just do surgery and take a pill for their cancer, okay? Because if it's not gonna help them, why should I expose the patient to the added risk of the radiation? Another example is we know that for certain age groups, also 70 and older, why check the lymph nodes if it's not going to change the patient management, when I know that the lymph node itself, might also increase issues of quality of life by causing swelling of the arm or lymphedema. So we become a little more critical in what we do and how we do it, so that we can obviously keep the patients healthy, but at the same time, we don't compromise their quality of life. So for me, that's one of the most exciting areas, because we can cure, but we can keep you functional and happy, and so you can carry on with your life.
Thank you so much, Dr. Mendez. We have so many compliments. Everyone is very happy that they were able to partake in this webinar. They learned so much and they sent lots of thank yous. And I'd like to close out with our family advisor, Susan Berger.
Well, thank you for the invitation.
Thank you so much. You're so informative, and I certainly did learn a lot. Want to talk a moment about Belmont Village. For 26 years, we've owned and operated best-in-class, fully licensed senior living communities, and we're founded on the belief that all seniors deserve to live happy, self-directed lives in a supportive community. And that's one that's filled with new friendships and interests, safety and security, quality and value, and above all, a place to call home. As we've learned, what you eat and drink, how much you socialize, are critically important, not only to one's well-being, but to one's brain health. And if we've learned anything from this pandemic, it is the importance of social connections and sense of purpose. In fact, socialization and a newfound sense of purpose are among the main reasons why residents have made the switch to living at Belmont Village. Whether you want the taste of a very active lifestyle in a very safe environment, or you just need some assistance with activities of daily living, Belmont Village is a vibrant community. We're designed to help our residents enjoy their golden years. And their families have added peace of mind because they know that our Belmont Village nurses and caring and well-trained staff are on site 24 hours a day to meet the healthcare needs of our residents in a very person-centered way. I receive so many calls every day asking about Belmont Village's memory care support. And for those who are experiencing cognitive impairment and early stage memory loss, Belmont Village provides a whole brain fitness lifestyle, one that is therapeutic in nature, and it combines our exceptional wellness model with mental fitness. This innovative approach to memory care is called the Circle of Friends. And the goal of all of our memory care programs, whether for those with mild or more advanced stages of cognitive decline, is to provide each resident with the just right challenge so they can feel successful and also have a newfound sense of purpose. And because these residents are among our most vulnerable, our caring and trained staff are trained not only to recognize those behavioral and personality changes, but to communicate with passion and understanding. And as experts in memory care, Belmont Village provides the needed support to their family through this most difficult journey as well. At Belmont Village, we strive to create a positive experience. That is our members. They include our residents, their families, and our employees. And we can continue to set new standards in resident and family satisfaction. We've also been recognized as a great place to work among our over 4,000 employees nationwide. And I'm proud to say that I'm one of those employees for the last 20 years. If you have any questions about a Belmont Village near you, or would like to learn more about our innovative approach to memory care, I hope that you will give me a call or send me a text or an email. Again, my name is Susan Berger. I'm a trusted family advisor. My phone number is 424-232-0701, and my email is sberger@belmontvillage.com. It is always my pleasure to assist families as they navigate the many options available in senior living, either for themselves or for their loved one. Please take the time to compare and don't wait for a crisis to react. Thank you so much for joining us today. Thank you, Dr. Mendez, and I look forward to seeing all of you at our next event. Have a nice weekend. Bye-bye.
Thank you.